pushes me to survive. So our emotions, they serve a purpose. They help us to move when we ourselves probably wouldn't move. Staying with the child until the feeling is past. That's an important one. So not abandoning the child when they're emotional. So components of ineffective emotion regulation: being oblivious to a child who is in emotional distress, anxiously, angrily, or frantically being in close physical presence with a child who is in emotional distress or anxiety. So they're already heightened, and now however they're feeling, you're feeling it and you're expressing it back to them. So that's just not a good combination. Wanting to know why the child is emotional, trying to immediately fix the child's problems, distracting the child from their emotions, trying to get the child to stop feeling their emotions, showing disapproval because the child is emotional, and abandoning a child who's in emotional distress. So I would say the abandonment is an important component. It's very important. However, distracting a child from their emotions is equally damaging, because we want to teach the child how to build a sense of resilience to feeling the emotion. And if we constantly distract them from what they need to become resilient to in the future, we're effectively limiting their coping abilities with dealing with emotions. So who qualifies as a secure attachment figure in childhood and adolescence? That's not right. Parents, grandparents, other siblings, adults. So with other siblings, I like it to be at least a 5-year age difference for the sibling to be qualified as a secure attachment figure. My sister is 6 years older than me. I never really saw her as my peer. I saw her as kind of like a second mom. So I still do to this day. Teachers, school staff, school administrators, coaches, helping professionals, and community police. If you live in an environment where that's active, where the police patrol and walk around, it's great for kids to develop secure attachments to the police officers, because they are here to protect and serve, and they need to feel protected and served. Characteristics of secure attachment figures: these people need to be mentally stable. So as a parent, you need to screen who you want to be an attachment figure to your child, and you do that the best you can. We can't go around giving everyone an MMPI or a personality assessment, but you just do the best you can. Ability to regulate one's own emotions. If you can't regulate your own emotions, then you can't regulate a child's emotions. Ability to build rapport with the child. So that takes skill and how to build rapport. Ability to attend to the child's emotional needs. Ability to provide comfort during emotional distress. Show a genuine interest in the child and what they think is important. Empathetically attempts to understand the child. Refrains from passing judgment regarding the child and refocus on promoting growth, and has the ability to see the child as their own. Now, if you can't remember any of these, if you're trying to be a secure attachment figure, if you at least have this, you're doing these naturally. If you can see that child as your own child, then you can naturally build a rapport with any child. So any person who comes into my therapy office, they're a second daughter, a second son to me. I mean, it's like I embrace my clients. I know there's a thing about hugging clients, but once I get to know you, you're getting a hug. Or you're getting, if we make a handshake or whatever it is, we're connecting. Because they need to know that I'm there for them no matter what. So why does modern attachment theory matter in relation to childhood and adolescent anxiety? So too many insecure adult attachments or not enough secure adult attachments cause children and adolescents and adults to feel vulnerable, unsafe, different, and alone in the world. So how many of you have heard the term, it's great to have a mentor? You need a mentor. So even in adulthood, having a secure attachment to someone who's older than us, who has more life experience, gives us a sense of security about where we're headed in life. These children are more likely to become extremely anxious, avoidant, and insecure if they don't have enough secure attachments. And they're less likely to explore and take risks, more likely to worry about uncertainty, and they're more likely to obsess about their vulnerability. So back to the old saying, it really does take a village to raise a child. Your child should be able to have multiple secure attachments to all the people in our community that they come across. That's an idealistic view of how things should be. But essentially, that's what works best in child rearing, to help children be able to adapt and feel comfortable in their environments to where they feel like they can take risks, and therefore the anxiety is reduced. So yes, we are still talking about anxiety, but attachment theory is very important in childhood anxiety. So thank you. I'm just joking this one. It just seems like a natural ending point. So, attachment theory and significant contributors to anxiety in school-age children. So, a lack of secure attachment figures in the school. So now what we're looking at is, through attachment theory, what causes anxiety at school? So lack of secure attachment figures at school, negative orientation to children showing emotion, high peer attachment, insecure adult attachment at home and in the community, and outcome-based school environments. So in the school system, children and adolescents, they need attachments to adults in the learning environment. If you ask your child who cares about you at your school, and they can't tell you one person, that's a problem. The child so we are responsible for creating those secure attachments, but the child is responsible for determining if the attachment is established. So if a child says no one cares about me at school, then I don't want to hear about ADHD, I don't want to hear about conduct disorder, I don't want to hear about anything, because the attachment is the most important thing right now. If they don't feel like anyone cares about them, then I don't care about their pathology at that point in time. I want to focus on who can we get to where when this kid is at school, they feel like this person cares for me without a doubt. They don't judge me. Whatever, I could have, started a fight with 10 people in one day, and they would have said, man, I bet those people really made you mad today. And just figuring out, what's going on, instead of suspension, or you shouldn't have done that, or things of that nature. So these attachment figures need to observe emotion. They need to be highly observant when children are emotional. They need to be with the child emotionally, encourage the child to feel emotion, empathize with what caused the child to become emotional. So I can imagine how that felt for you. That must have felt terrible for you. Try and identify with the child any real or reasonable dangers. So actually that should say adolescent. So that's speaking to adolescents who have the ability to kind of use their prefrontal cortex to identify any real dangers if they are anxious. And empathetically and warmly demand the child cope with the situation. So this is a strong component of helping children become resilient to their anxiety. They need someone to develop a relationship with to where they can go to and feel that anxiety without the shame of feeling it. And then that person looks into their strengths because they have a rapport with the child, and then they empathetically and warmly demand the child to cope with the situation. So I understand how you're feeling. That must have felt terrible for you. But in the past, I remember when you did this, and I remember when you did that. And I know you can go and do this. So, and you empathetically demand that they cope with the situation. Now, there's a saying, you can talk, or what's the saying? I can talk about my family member, but you can't. So, because you have a relationship with your family member, you have a rapport with them. So, you can't demand coping from a child if you don't have rapport with them. If you have rapport with them and you demand coping, when they go into that situation, they're not going into it alone. They're going with you. You may not be there with them physically, but they feel your presence. They feel your encouragement. They feel your confidence within them to cope with it. And they're no longer going into that situation alone. So, and humor helps. Humor helps with the establishment of rapport and it helps them to take away the seriousness of the anxiety that they feel is dangerous. And humor helps to lighten the mood and say, it's not exactly dangerous. This doesn't necessarily have to be overwhelmingly bad. It feels bad, but we can lighten the mood still. So I want to speak about this for a second, because this is highly important, the empathetically and warmly demanding child to cope. So at the Anxiety Treatment Center, we do a lot of exposure therapy with adolescents. And luckily we have the Crossroads Mall in Portage, which is amazing for doing exposure therapy with adolescents who are socially anxious. So I don't frequently visit the Crossroads Mall to shop. So if you all do see me at the Crossroads Mall, I am probably in session with an adolescent doing exposure therapy. So I had one adolescent who was 15, and he had an avoidant personality disorder. He felt very inferior about how he came across to people. So we worked up this hierarchy of fears. He had a fear of being awkward in front of people. So I had him grasp some change, and he would walk and he would just purposely drop the change in the mall, and then he would pick it up. And I asked him, after you drop the change, look around. Who's looking at me? And almost every time he said, people glanced for a second, but no one really cared. So we started to desensitize the fact that his behaviors were awkward. We purposely tried to do awkward behaviors. I had him go up to one of the food kiosks and purposely order something that's not on the menu, and notice the response from the person who he ordered from. And what I would do is I would later go back and I would interview the person who he ordered from. And I would say, did it seem awkward from you that he ordered a hamburger at an ice cream shop, where you guys don't even have a grill here? And, they would say, no, people do that all the time. They think we have something and they order it and, we don't have it. So I would relay that back to him. Well, long story short, we got to an exposure where he couldn't get past it. He couldn't get past asking someone for the time, because that was just something that he'd never done in his life. And he felt that it was extremely awkward to do that. And so I had a rapport established with him. I empathized with him. I understood his anxiety. We talked about his cognitions and how he knew his fear was unreasonable. He couldn't get past that, what we call the terror barrier. He couldn't get past that moment of terror when you can do something, but you fail to pull the trigger and do it. He knew that it wasn't dangerous. And we were stuck on this part for a long time in the exposure. And one thing that I forgot to do, which prolonged his treatment, I forgot to empathetically demand him to cope. I completely forgot that step for some reason. So, I grabbed him up. I said, hey, I know this is bad. I know it feels bad. If I was in your position, I'd feel the same way. But I know you can do this. You have the skills to do it. I know you can do it. And after I said that, he went and asked someone for the time. Then he asked another person. And then he asked another person. That was all he needed. Not all, but it was the last piece. So that just highlights how important it is for us to empathetically and warmly demand coping instead of just demanding coping. Children today are experiencing much more separation from adult attachment figures at home and at school. Primarily in our society, people have or parents have high workloads, divorce, detached parents, economic hardships at home, isolated extended family. And I don't go to school settings that often, but I know you guys are busy. I know you're extremely busy. So there's not always that time to have one-on-one time with kids. Excuse me. So when children cannot lean on us as adults, as attachment figures, they become extremely preoccupied with who they can lean on. Who can I depend on? Who can be an attachment figure for me? So according to attachment theory, negative orientations to children's emotions are also a cause of elevated anxiety in the school. So when we ask a kid, what's wrong? So this isn't what we're saying, but a lot of the times this is how the child interprets it. Their interpretation may be conscious or subconscious. So the child may interpret it as your emotions are not normal. When we ask what's wrong, wrong is another form of using another word of pathology. So something's wrong, something's abnormal. So what's wrong with you? And we may be coming from a very good place when we ask that. So why are you crying? Also, we're trying to come from a good place. What's wrong? Why are you crying? To the child, that's disapproval. It's disapproval that they shouldn't be crying or they shouldn't be anxious. Hey, look over here. So trying to distract them from their emotions. We are robbing them from building resiliency and feeling their emotions. Child becomes self-conscious about being emotional when we do these things, and they internalize and repress future feelings because they don't want to be abnormal. They don't want to be seen as someone who's doing something that other kids aren't doing. So they repress those feelings of anxiety and frustration. So as a society, we have become emotionally phobic. So anytime children become anxious, we respond as if it's a problem instead of just being there with the child. And this is all culturally based. It's just how we in Western society respond to emotions. So we become highly alert when children are emotional, and we look to fix the problem. There's something wrong here. There's emotion. This is wrong. Kids need to experience anxiety in its full in the presence of an attachment figure. Feeling our emotions helps build resiliency. So next we're going to talk about peer attachment according to attachment theory. So when kids aren't attached to adult figures, you can be assured that they are attached to their peers. If they can't find attachment within adults, they're going to look within their peers for attachment. So problems with peer attachments. Peer attachments are hardly ever secure attachments. And that's just because the people they're attaching to don't possess the emotional maturity to be able to regulate each other's emotions properly. So most likely, peer attachments are avoidant attachments. So they're trying to fit into a peer group, but the peer group continuously neglects their emotional needs. They may poke fun at them in good humor. However, that good humor is hurting the child. Ambivalent anxious attachment. So peers at times may meet all the person's needs, and then the next week they meet none of their needs. So there's this anxious kind of feeling of where you stand among your peers. And disorganized attachment. So this can be associated with things such as bullying. So their needs are never being met. So it can be either through bullying or it can be through just no one's noticing them. So they're never really getting any interaction with people. So on a day-to-day basis, some days they fit in, some days they don't fit in with peer attachments. And emotions are hardly ever regulated among peers. Usually peers try to hide their emotions from other people unless they're a really close friend that they feel comfortable with being emotional. Peer interactions begin to define the child. So when peer interactions define the child, you as a parent are no longer defining the child. The peer interactions are not defining that child because for some reason the secure attachment is not as strong within the home as it is at school. And so the attachment that they're seeking at school and what happens as a result of that attachment seeking starts to define who they are as a person. So children need us much more than their peers. So secure attachment is beyond baby bonding. So I still today call my mom mommy, and I still call her and ask her for advice. If I have a paper that I'm not sure about, I'll send it to her. She'll edit it for me, send it back. I mean, that gives me great security in the world to take risks and be adventurous, to know that I have someone who has my back like that. We need secure elder attachments throughout our lives. So this talks about what we talked about briefly, but I want to focus on insecure attachments in the home. We don't want to be so quick to judge that these insecure attachments at home are because of purposeful neglect. So there could be a lot of situations going on in the home where you're just experiencing some sort of situation that's taking your attention off of creating an attachment with your child or just being there for your child. So learning outcomes. So outcomes and consequences based in the learning environment, So these are not problematic. Learning outcomes, why do I keep saying that? I'm doing my PhD in education, and we've been doing learning outcomes, so I keep switching the words right now, I apologize. So outcome and consequences based on learning and environment, these are not necessarily, they're not bad, but they can be harmful to children who have no secure attachments when they're constantly being evaluated in the learning environment, and they have no home base of confidence to support them. So consequences for being emotional, consequences for acting like a kid, consequences for not acting like an adult, consequences for having a learning style not accommodated for by the teacher, consequences for having a bad day. So their worth becomes based on school outcomes, grades, behavior, emotional stability, social skills, satisfactory, unsatisfactory, good or bad. So they start to identify with that because they have no secure attachment to coach them up and to instill some worth in them. Their outcomes at school become their worth now. So at times, educational environments are too behaviorally focused. Again, this is speaking to attachment theory, and specifically with kids who have no secure attachments. Behaviorally focused environment can be harmful for them. Teachers are teacher-centered instead of student-centered, and the lack of teaching pedagogies that emphasize student-centered rapport building. So next we're going to get into community approaches to assisting children and adolescents positively cope with their anxiety in school. So what we do at the Anxiety Treatment Center is we implement a PACE system for children. And I'll go over what PACE means. Doing things such as school-wide PACE training and rapport building with students to form modern attachments from an attachment theory perspective. So the focus of PACE training with staff or parents is to teach them how to establish a secure attachment with children and adolescents suffering from anxiety, emotional regulation of that child's anxiety, and empathetic and warm demands for coping with anxiety. So that's the focus of the PACE program, is to help train them how to accomplish this. And this helps anxious children move forward and tackle their anxiety and feel the anxiety because they now feel that they have someone who is invested in them. Components of the PACE model. So playfulness, acceptance, curiosity, and empathy. So playfulness with children allows them to cope with their feelings of anxiety. Playfulness reassures that anxiety is temporary and will never harm them, creates safety in the environment, and releases oxytocin in the brain, which creates bonding. So playing with kids, if you want to create a bond with a kid, play with the kid, and you'll create that bond very easily. Creating an atmosphere of lightheartedness as well. So acceptance, unconditional acceptance increases a child's sense of safety. Be accepting of a child completely regardless of behavior. However, this does not mean that you have to agree with their behaviors. You just need to be accepting of them. Accept and respect their right to their feelings. For curiosity, so curiosity without judgment. Wondering about the meaning behind the behavior. Not interpreting or fact gathering, we're just wondering. We're not trying to assess the child. Just getting to know the child and letting them know that. So I just want to know about you. I just want to get to know you. Curiosity lets a child know that adult wants to understand them, and helps give insight into adolescents about themselves. So when we wonder about adolescents, that actually helps develop insight within them. So empathy lets the child feel the adult's compassion for them, showing the child that their life is important to the adult. The adult feels the child's anxiety. So being empathetic means actually putting yourself in that child's shoes and feeling what it feels like to be that child in the moment. The adult provides emotional support and comfort by being present. The adult communicates and highlights a child's strengths. The adult empathically or empathetically demands that the child cope with their fear and anxiety, which helps build resilience in the child. So in the school setting, we can use 504 plans to incorporate resiliency and secure attachments within children. So IEP plans are specifically, I know I'm preaching to the choir here, but IEP plans are specifically for the school-related anxiety issues. I believe those 12 or 13 related issues. However, 504 plans can be used with any type of disability, including anxiety. So what you would need is a letter from the therapist. So I write letters, a letter from the parent, and maybe some more supporting documents, maybe a diagnosis, and the school make a decision about creating a 504 plan to accommodate that child. So the 504 plan that I always suggest, that we only suggest at the Anxiety Treatment Center, is to pair a child with a staff member trained in PACE. When a child feels overwhelmingly anxious, they can be excused to see a PACE-trained staff member. Staff member regulates the child's anxiety, lets them feel it in safety without distracting them from it, empathetically and warmly demands the child to cope with their anxiety. Oh, sorry. Did you get it?
Do you have this on PowerPoint?
Yes, I can email you. I believe you all registered your emails, so I can send the PowerPoint out.
Okay.
So therapeutic approaches to treating anxiety using attachment theory, cognitive behavioral therapy, and exposure therapy and response prevention. So this is the treatment approach that we use at the Anxiety Treatment Center to treat children and adolescent anxiety. So with children ages 3 to 12, we use a family systems approach and a solution-focused CBT approach. So parental consultation is preferred much more over individual therapy for these children, because our theory is that the child is anxious because they're experiencing a lot of insecure attachment, either at home or at school. Maybe they have great secure attachment at home, and they have no secure attachment at home, or vice versa. So adult CBT protocols are mostly ineffective for this population because of the immature nature of their prefrontal cortex. They're not able to comprehend cognitive techniques between 13 and 12. Difficult for this population to respond to cognitive techniques such as cognitive restructuring, rationalizing, mindfulness, and here and now techniques. Now, these are helpful, so we're not saying that these don't help children, but we believe there are more effective ways than addressing them cognitively when they are not developmentally ready to respond cognitively. So the treatment approach, we teach the PACE model to caregivers in the family unit, and we initiate a 504 plan if that is necessary. So if they are experiencing extreme anxiety that is impairing their function in the school system, then we will initiate that 504 plan based on the PACE model. We coach parents how not to enable maladaptive behaviors in the child. So we teach parents not to facilitate avoidance behaviors. So anytime the child is avoiding, we want to move the parent to empathetically and warmly demand that child cope with the situation. Being a person of reassurance seeking, again, we don't want to enable reassurance seeking. So if they're constantly coming to you for reassurance, we want to relate to them that they can cope. And enabling safety behaviors. So that's just monitoring your child to see what things they're doing when they are in unavoidable anxiety-provoking situations that make them feel safe. And letting them know, you can take your hands out of your pockets. You're strong. You need to have your hands in your pockets. Or if they want to have a cap on to avoid eye contact. People love seeing your eyes. You have good eyes, and you make good eye contact. You don't need that hat on. So something to that effect, and a little bit warmer than I just said it, and a little bit more empathetic. Conducting individual therapy with the child. So at this point, I would do loose therapy with the child. I actually wouldn't call it therapy. Basically, what I do with children is I work on building an attachment with them. I work on having children and adolescents have a secure attachment within, or me being someone they can see as someone who cares about them, and thus that facilitates the secure attachment. So we revisit anxiety-provoking situations throughout the week, and we help them to regulate those feelings they had. So we'll revisit it. If we can elicit the feeling in therapy, then we'll just sit with it. If we can't, we'll just talk about the feeling. Practice arousal control techniques. So we'll give them deep breathing techniques, actually diaphragmatic breathing or belly breathing. And for adolescents, we'll do belly breathing along with progressive muscle relaxation. Highlight the child's strengths and empathically and warmly demand that the child cope. So I project what's happening in your week that you're concerned about, and they'll talk about all their concerns. And we'll just talk about how they can cope with it all. We'll go through every single situation. Yep, you can handle that. I've seen you do that before. You can do it. I know it feels horrible, but I know you can do it. So for adolescents, ages 13 to 25, we primarily focus on family systems, CBT, and exposure therapy. So the family systems approach, we work to increase the amount of secure adult attachments within the adolescent's life. Additionally, we work to decrease peer attachments. So we're not looking to decrease friendships. We're not looking to say, parents limit the amount of friends your kids have. What we're looking to do is decrease how attached they are to their peers. We accomplish that by highlighting, how parents are much more secure than your peers. We look at the differences, what your parents do to you as opposed to your peers. And it kind of helps them to kind of reevaluate the security they get in their peers versus the security they get within their parents, their grandparents, their uncles, their aunts. So we direct the parent at the kid, and we direct the kid at the parent, or if there are more people involved in the therapy for the kid, that we can come in and train them in the PACE model, we'll direct them to each other in terms of creating that secure attachment with each other to where that person's needs are being met consistently. So we decrease screen time attachment. So we're not decreasing actual time in front of the screen, we're decreasing their attachment to the personalities on the screen. So we highlight how these personalities compare to your secure attachments within your mom, your dad, your grandma, your grandpa. So what does Miley Cyrus give you that your mom, gives you, that doesn't give you? Something to that effect. So, and we'll highlight, that's a longer process with teens. I would say it's probably about a 3 to 5 session process where we kind of get them to see that the people who they see on TV will never offer them the security that their actual community can. So it helps them to reach out more to their community for security rather than what's on TV. So after that, we get into cognitive behavioral therapy. We identify maladaptive thought patterns by tracking the situations. So we have the child journal or the adolescent journal things that cause them distress in their week. And what we do is we look at what are the triggers, what are the thoughts that they're having, and what we try and do, and most likely we can do this fairly quickly, we identify what are the hot emotions and what are the hot cognitions they're feeling. And we use the word hot to identify this is the thing that's moving their anxiety. So they have a core belief that's strong, and that core belief is really what's driving them to become anxious. So they may have a core belief that I'm unlikable. And their underlying assumption is if I try and make a friend, then most likely they won't like me. And that's what's driving their anxiety. So what we do is we work on restructuring that with evidence for and against, using the prefrontal cortex to derive a conclusion of, is this based on evidence or opinion? We test the validity of the thought. So we do that by role-playing, observational experiment exercises, surveys, and behavioral experiments. So we may role play the person, trying to establish a relationship with me, and I'm a peer, and I'll just really hammer them. I'll be negative. I don't want to be friends with you. You're not likable. And what I'm doing is I'm showing them how ridiculous it is that someone would say that to them. So we're kind of learning that, do people normally really act like that when you try and get to know them? And it kind of makes them feel a little bit more at ease, because essentially that's what their fear is telling them, that the person's going to say, I don't want to be your friend. So when we actually say it and do it, they see that it is probably not that probable that that'll happen. Observational exercises, so they'll observe their environment. They'll observe other people making friends and seeing how that happens. So next we move into exposure therapy and response prevention. So we gradually expose the adolescent to what they're afraid of. So first we start with simulation. So we have a fear room in the Anxiety Treatment Center where we use U2 a lot to find some. That was my anxiety. Did you guys notice that? Did you see that? Anxiety is great. I was prepared. Whatever was coming through that door, I was prepared. Probably just go through this. That was the only thing I could do. But we gradually expose them to what they're afraid of. And in that room, the fear room that we use, we start with simulation. So we watch videos. And by watching videos repeatedly of what they're afraid of, or if we can't find a video of it, we'll imagine it. By doing that repeatedly, they desensitize to that fear. They become so used to it that their fight or flight response is now reduced. So we use real life situations as well, such as going to the mall to do exposure. And we either do a gradual exposure where we slowly work up the hierarchy of fears, or we just flood it. It depends on how motivated someone is to get over that fear. So lastly, we just want to limit the responses of the 4 primary maladaptive behaviors while we are doing exposure therapy. So that's the response prevention component. We want to make sure that they're not avoiding and primarily engaging in safety behaviors while we are exposing them. So if someone has emetophobia, which is a fear of vomiting, and we are exposing them to watching videos of someone vomiting repeatedly over and over and over again, essentially my job as a therapist is to make sure that they are not closing their eyes at the point where someone actually vomits. I want to make sure their eyes are open, that they are seeing it, that they're taking their fear in, that they're moving towards their fear, that they're building resiliency. And I want to check for safety behaviors. So maybe at the mall, the example I gave you earlier when someone was asking for the time, maybe as he was asking for the time, his hands were in his pockets, or he was holding on to a drink, or he was self-soothing himself. So we want to limit those, because essentially what they'll say is that you can't do this without self-soothing yourself. You can't handle this. You're not resilient enough to handle this without self-soothing. So we want to limit those safety behaviors. And then rumination and worry, we just discussed if they did any of that during the exposure, and can we work to limit that. So that is the end of the presentation. I tried to take slides out to make room for questions, but everything just seems so pertinent, so I'm sorry. I'll be up here for any questions you guys have. Oh, thank you.
Hand delivered.
Yep, there are cards and brochures here for the Anxiety Treatment Center if you guys would like to take some. So thank you all for coming out.
Thanks, Sean.
Yes, thank you.
Lunch is set up, right, Barb? So you guys can enjoy your lunch, and we'll start back with afternoon sessions at 11:45. You might still be on.
Oh, she might.
She might be. You want to grab her, right? Mine did too. I had to put it back together. Yeah. It was, well, mine actually goes here. So I was just, see, I don't even, I just, no, for the PowerPoint? I was going to ask you that, Sean. I had someone else ask. So you're going to send out your PowerPoint? Is that what?
I need to get access to all the
Okay.
How are you? I'm doing well. I know, it's been a while.
We don't have a list. That's what I was going to suggest. I actually handed it down, trying to work out something, because someone said it on
I
the
just started.
There you go. You're over.
I'm very sterilized myself. I need this for 7 years. It's great.
How's it going? Right? Well, it's good. Makes it go fast. Yeah, you too. Oh, thanks.
So you would contact on the website the executive treatment.
We just had a workshop.
So contact.
Yeah.
Yeah. We have a twin head.
I know.
Exactly what I had.
Oh, yeah. Okay, good. Because right now we're like here for her life.
Very well. Like they're close.
My brother.
Yeah. It's really good. All right. Yeah.
Obviously not current, but I'm reaching out to you.
I helped her. If she's scheduled.
Just so like I can say, I have several different things, but also yeah, and beverage cooler in here. There's also beverage cooler in the area too. I mean, everyone else is going to be floating around. I mean, we'll try to get this session at some point. So, but just to recall, the first session will be the 45 to 115. Yeah. And so we have the table set up here, and Brad, Howard, we use for Michigan Works, is there's a handout there. And then so we'll have a 15-minute break. We'll just hold the audience because they basically have 3 sessions to choose from. So they're going to choose the first. So they'll have a 15-minute break, and then 1:30 to 3 will be a whole new, really, as he said, rinse and repeat. If you don't want to hear it, it's got to rinse and repeat, you know. But probably those are going to be
Kind of a, talking about in the moment.
I'll let you run.
So I should get you in contact with your native. Okay. Because I don't do the PowerPoints. I'm too busy. So.
What's back there?